access to. The findings of our small project around data, which lead into this mapping project, were that people were really drowning in data out there. So program managers and clinicians and health professionals and services and agencies found that there was a lot of data, but it was very chaotic. There were multiple systems, there was a lot of double entry, there was no link between clinical data and data for monitoring services. It was not fine-grained enough, it was often very time-consuming to collect. It wasn't able to be shared very easily, and so on. So there were lots of problems with existing data. I'm not saying there wasn't data out there, but there were problems in using it and understanding it, and having the skills to do that. And it was poorly integrated. So we embarked on this project around trying to take that issue around access and take this issue around integrating data. And those are the two issues we took into this study. So these were the findings from that case study project, and the relevant one here is that we recommended that there was this process in the region of reflexively monitoring the system, and that's where the innovations in this data project came about. So we are embarking on a process of trying to integrate social data, disease data, psychological data, environmental services data, and infrastructure data into some usable maps for planning, particularly on the planning by Medicare locals and primary care partnerships are the key users of this project. So here's some of the early maps we've generated. This is what's called the Inner Northwest Metropolitan Medicare Local, and there are 4 Medicare locals in the region, and we hope to have data similar to this once we work with the other Medicare locals for the purposes of today, just the one. So that's mapping green spaces, obviously, and health services, not specifically diabetes related or mental health services, but that's another layer we want to go into. But we've got general practices, hospitals and community health centres. If you overlay that with CEFA, that's socioeconomic indexes for areas, index of relative socioeconomic disadvantage, you can see the red areas, obviously, perhaps no surprise, are in the north region of the Medicare local. The services tend to be located, obviously, in the areas of lower need and lower socioeconomic disadvantage. We've then added onto that a tool where we can interrogate the data sets that we've integrated around overlaying CEFA scores, diabetes, prevalence, depression, and characteristics of services. So this is an early attempt to integrate the data. So this particular query looks at areas that are the lowest 3 deciles of socioeconomic disadvantage, so the most disadvantaged 3 deciles, and a relatively high prevalence of diabetes, and have a relatively high prevalence of depression, and where people in those areas have with no access to GPs, walking distance from 500 metres, GPs who are bulk billing, and have after-hours services and provide any Sunday services. So the areas that show up on the next map are the areas within that region that fill all of those criteria, and they are the yellow spots on the map. So the services here don't represent only those services. Nevertheless. So these are the areas that satisfy all of those criteria. So people living in those areas are socially disadvantaged, living in a socially disadvantaged area, have a high prevalence of diabetes and depression, and do not have access to, within walking distance to GPs with after-hours services. So that's the beginning of an attempt to integrate and interrogate the sort of data that we're trying to bring into the project. And you can drill down onto that and get area labels, obviously, and so that's the early work we're doing, and obviously we want to add to that more data and we've presented this to the users, primary care partnerships and Medicare locals, and we're progressing it over the next 3 months. I think Jane was going to present.
Firstly is that I think it's really exciting to see the maps coming up, because about 8 years ago I was in the United States in Washington, and there's a Robert Graham Centre there where they do this kind of work across the United States, and it was really exciting to fiddle around and look at all the things they could look at there, where they have a very poor primary care service and a difficult health service, and to think that we didn't have anything like it here. And so I think that to see it starting to happen is very exciting. And one of the things that the challenges is that we've got an opportunity with health reform at the moment to think about ways that local health planning can incorporate social and health data, but it's a very difficult thing to do well. So many stakeholders, there's multiple layers, there's lots of activity across many domains of people doing all the similar things all over the place. And yet it's interesting to think about what would access to innovative data sets like this have at helping people plan services locally. And that's what makes it interesting, I think. But the data, has to be really accessible and reliable, meaningful, and influential in the way that we think health reform needs to be driven. And I think that's the other thing that comes into what might be behind simple maps or even complicated maps. There's a lot of work that needs to go on behind the scenes to think about what you put on the maps, what's available, at what level of detail is it useful, how's it going to be used most effectively in the community where they're planning services. So I think now the thing is to see what happens with the user group that you've got together, and I think the meeting went well the other day from John's brief report, is that right?
Yes, no, it was good. They're very engaged with the process.
Yeah, so just sort of thinking about, well, what is it that would be useful data, and how would it be used, and how might it drive the healthcare reform that is underway, and how might it influence decision making. So I think there's a lot of potential with the project, even though it's not it's tricky data to get and to be reliable and all of that. There's a lot of we don't know how absolutely reliable it is, but at least it gives you an idea of what you get when you put this sort of data in. So that's all I had to say. Sandy, did you want to add anything? Okay, thank you.
Great, thank you.